Pharynx and larynx, pharyngeal diverticulum, pharyngeal pouch, Denker's diverticulum. Definition: protrusion of the pharyngeal mucous membrane through Killian's dehiscence, triangle in posterior wall of the pharynx between the syropharyngeus muscle above and cricopharyngeus muscle below. Pathology: type, pulsion diverticulum, pathogenesis, failure of relaxation of the cricopharyngeus, achalasia, during contraction of the pharyngeal muscles above it during swallowing, increased pharyngeal pressure, protrusion of the mucous membrane, fills with food at every meal, and progressively increases in size, displacing esophageal opening. The pouch descends towards the mediastinum, but often turns outwards, usually to the left, to appear in the posterior triangle. Clinical picture: type of the patient, elderly, male to female, 2:1. Symptoms: asymptomatic, early cases. Symptoms identical to foreign body in the throat sometimes, and in long-standing cases, dysphagia, regurgitation of undigested food after meals, eructation of gas and gurgling noise in the neck, irritable cough from overflow of food into larynx sometimes, and progressive weight loss leading to cachexia. In advanced cases, signs: in third of cases, large pouch forming visible swelling in the posterior triangle of the neck, which increases in the size by drinking and decreases in the size by pressure. Investigations: barium swallow. In early cases, bulge in posterior wall of the pharynx. In late cases, flask-shaped pouch, sometimes with a fluid level. Manometric studies and oesophagoscopy not recommended as it may lead to perforation. Treatment: when pouch is large-sized, surgical excision of the diverticulum. Cricopharyngeal myotomy to avoid recurrence. Its neck closed in 2 layers. Less invasive operation involving excision of bar of tissue between anterior wall of diverticulum and posterior wall of esophagus by endoscopic stapling. Retropharyngeal abscess. Acute retropharyngeal abscess, etiology, tonsillitis, leading to suppurative inflammation of the retropharyngeal lymph nodes. Clinical picture: type of the patient, children less than 4 years, commonest. Symptoms: neck rigidity, saliva dribbling from the mouth, food regurgitation. Signs: bulging in the posterior wall of the pharynx, fluctuating swelling may be felt digitally. Treatment: drainage under general anesthesia using cuffed endotracheal tube. Push pair of forceps into the abscess cavity and pus is evacuated. Antibiotic therapy. Chronic retropharyngeal abscess, that is a cold abscess, etiology, TB of cervical spine. Clinical picture: tuberculous toxemia, fluctuant swelling in the posterior border of the sternomastoid muscle, retropharyngeal swelling, cervical spine, caries. Treatment: anti-tuberculous treatment and repeated pus aspiration. Tumors of the pharynx. Neoplasms of the nasopharynx, type, benign angiofibroma, causing massive bleeding. Malignant squamous cell carcinoma, 70%, lymphoepithelioma, 10%, lymphoma, 15%, mixed salivary tumors, 5%. Etiology: Epstein-Barr virus is a possible cause. Clinical picture: nasal symptoms, oral symptoms, metastatic cervical lymph nodes, and paralysis of cranial nerves. Nasal symptoms: early, slight intermittent epistaxis and nasal tone speech. Later, nasal obstruction and postnasal discharge. Oral symptoms: Eustachian tube obstruction, unilateral deafness, or secretory otitis media. Metastatic cervical lymph nodes may be the first presentation. Enlargement of upper deep cervical lymph nodes may be bilateral and may be confused with malignant lymphomas. Paralysis of cranial nerves due to proximity of the neoplasm to the skull base. One or more of the cranial nerves may be involved. Involvement of trigeminal nerve. Pain in the side of the head. Investigation: CT scan or MRI, biopsy. Treatment: the main lines, radiotherapy, chemotherapy are the treatment because surgery has a very limited role. Neoplasms of laryngopharynx, epilaryngeal tumors, epiglottis, pyriform fossa, areoepiglottic fold, and lateral wall of the pharynx. Incidence: more in males at the age of 50 to 60 years. Clinical picture: dysphagia, sore throat, cervical lymph node metastasis, foul-smelling breath, change in the quality of phonation. Investigations: laryngeoscopy and biopsy. Post-cricoid carcinoma, incidence more common in females about the age of 40. Etiology: occurring on top of Plummer-Vinson syndrome. Site: anterior wall of the hypopharynx at the level of the cartilage. Clinical picture: symptoms: pain in the throat, referred to the side of the neck or the ear due to stimulation of auricular branch of vagus Arnold nerve, foul smell of the breath and loss of weight, and finally dysphagia, which is a late symptom. Signs: inspection: forward bulging of the thyroid cartilage and trachea, palpation, loss of laryngeal click. This is called Morris sign. Investigations: for diagnosis, plain X-ray, barium swallow, endoscopy, and biopsy. For staging, CT, bone scan, chest X-ray. Treatment, operable and fit patients, total laryngeotomy, and stomach pull-up, plus pull dissection of lymph nodes, plus permanent tracheostomy. Another method to replace the pharynx, pectoralis major and myocutaneous flap. In operable and unfit patients, external irradiation. Neoplasms of the oropharynx types, benign cavernous angioma. Treatment, sclerosing solutions, laser, cryosurgery. Malignant, squamous cell carcinoma. Clinical picture, early, slight discomfort or pain, which is referred to the ear by the tympanic branch of the glossopharyngeal nerve, Jacobson's nerve. Dysphagia, blood-tinged sputum, metastasis to cervical lymph nodes treated by radiotherapy or pharyngeectomy. Wounds. Definition. Forcible loss of continuity of soft tissues by mechanical trauma. Types of wounds are open or closed. Incised wounds, sharp objects such as razor or knife, and this is the cause. Wound is longer than deep with clean-cut edges, no much tissue destruction. There is usually extensive hemorrhage. Tendons and nerves are liable to be cut. Bites, maybe animal or human bites. Lacerated, contaminated wounds with high incidence of infection. Penetrating wounds cause penetration by a pointed object as a knife. The depth is more than length. Risk of injury to deep important structures is high. The external opening is small. Poor drainage, more infection. They are deceiving, and the surgeon may suture an abdominal stab wound and miss an injured viscous inside. Abrasions, scraping away of superficial skin layers due to friction with a hard, rough surface. Very painful due to exposure of sensitive nerve endings. Requires cleaning with a bland antiseptic and non-adherent dressing. Missile wounds are very serious as the bullet transmits its high kinetic energy to tissues. The kinetic energy is calculated by formula equals mv2/2g, m for mass of bullet, and v for velocity, g gravity acceleration. High velocity missile injuries, rifles, are much more serious than low velocity ones, pistols. Damage results from the following factors: direct damage by the missile track, shock waves which precede the missile, and temporary cavitational effect. If the missile strikes a bone, fragments act as secondary missiles, leading to more damage. Hematoma occurs if amount of bleeding is excessive, at first cystic, but clots within hours, liquefy later. If small, aspirate by wide-bore needle. If large, evacuate by surgical incision under aseptic precautions. Lacerated wounds cause severe violence with blunt objects as road traffic accidents. Shape irregular, and tissues are severely traumatized and devascularized, usually contaminated, increasing the risk of infection. Inflammatory edema will develop after few hours, increasing tension inside the wound. Secondary ischemia occurs, commonly associated by degloving injury. Skin and subcutaneous fat are degloved from the underlying deep fascia. Devascularization follows in few days. Management of open wounds. First aid. Management in theater. So the first aid, management of the multiple injury patients, ABCD. Ask about timing and cause of injury. Form an idea about the possible injured structures. Stab in femoral triangle means injury to femoral vessels. In missile injuries, injury of structures which are far from the tract of the missile. Prophylaxis against tetanus, prophylactic antibiotics in deep or lacerated wounds, against anaerobic infections. If there is bleeding, stop it by direct local compression using sterile dressing and tight bandage. Don't apply a tourniquet except as a temporary measure before taking the patient to the hospital. If a fracture is suspected, plain X-ray and splint the fracture. If distal pulses are not palpable, reassess after treatment of shock. If still not palpable, urgent duplex is mandatory. Management in theater: clean the wound by saline irrigation, remove foreign bodies, fertile medium for microorganisms, and sterilize by antiseptic, povidone, iodine, or betadine. Repair any vascular injury according to the usual principles. Repair injured nerves or tendons in clean incised wounds, but in contaminated wounds it's better to delay the repair. Repair clean incised injury of a muscle by mattress sutures. Ischemic or necrotic muscles should be completely excised. Leave the deep fascia opened in contaminated wounds where there is extensive tissue destruction. Skin, clean and early, less than 6 hours, primary closure. Contaminated or late, delayed primary closure. Lacerations, debridement. In degloving injuries, skin viability is doubtful. Delay the decision to a second look after 3 to 4 days. The deep fascia and skin should be left open. If there is a skin defect, the patient will be reassessed later when the tissues are healthy. Then skin graft or flap may be performed. In associated fracture, there is any possibility of infection. Stabilize the fracture by external fixation, as internal fixation spread infection to the bone. All missile injuries require exploration. In contaminated wounds, don't do nerve or tendon repair. Don't close the deep fascia or skin. Characters of necrotic muscle, dark red or gray in color, doesn't contract if pinched, and doesn't bleed if incised. And finally, don't forget that contusions are caused by blood trauma, leading to extravasation of blood through the injured capillaries, and pain and swelling occurs. The color is at first bluish due to extravasated blood, later turns to green or brownish. Elevation of contused areas minimizes edema, and apply a local anti-inflammatory ointment. Wounds healing and management. Stages of wound healing. We have 3 stages. Hemostasis and inflammation phase, lasting for about 5 days. Injury of blood vessels leads to aggregation of platelets to subendothelial collagen and activation of the coagulation cascade. Cytokines and growth factors are released from platelets, stimulating chemotaxis of leukocytes, macrophages, and lymphocytes. Importance of macrophages. They play an important role in phagocytosis and wound debridement, releasing further growth factors, leading to recruitment and activation of fibroblasts and endothelial cells. Proliferation phase. Fibroblasts proliferate from surrounding tissues, leading to formation of collagen fibers. Endothelial cells proliferate from intact venules. New capillary buds, which together with the fibroblasts form granulation tissue. Epithelial cells proliferate from the wound edges. Basal cells of the epidermis undergo mitosis and migrate to close the epithelial defect. Young epithelium is thinner than normal and possesses no sebaceous sweat glands or hair follicles. Maturation and remodeling phase. Deposition of collagen in the wound, collagen 3, first then 1. Remodeling for about 1 year. Collagen fibers become thicker and arranged along lines of stress, increasing tensile strength of the wound. Never attains its full original tensile strength. After 3 weeks, 20% of its final strength, and after 3 months, 80% of its original strength. Types of wound healing. Primary intention, secondary intention, and tertiary intention. Primary intention in clean wounds. They are immediately closed by sutures or clips. Healing occurs with minimal fibrosis, a nice, neat scar. Secondary intention when the wound edges are not approximated or when gapping occurs as a result of wound infection. Healing occurs by infilling with granulation tissue, ugly scar. Tertiary intention, wounds which are contaminated and left open for about 5 days. If there are no signs of infection, delayed primary sutures. Components of wound healing. Wound contraction decreases wound size, starts immediately after wounding, and continues for 2 to 3 weeks, done by special myofibroblasts containing smooth muscles, protein actin, and granulation tissue formation, later replaced by fibrous tissue. Epithelialization in clean-cut wound, 48 hours, in gapped wound after gap filled with granulation tissue followed by contraction. Participants in wound healing: protein, vitamin A and C, zinc, calcium, copper, and magnesium, platelets, polymorphic nuclear lymphocytes, macrophages, lymphocytes, fibroblasts, endothelial and epithelial cells, granulation tissue, cytokines, platelets derived, and tumor, necrosis factor alpha, interleukin 1, and fibroblasts. Factors affecting wound healing. General factors: age. Healing is slow in elderly due to decreased rate of protein turnover. Nutritional state: protein deficiency, decreased collagen synthesis, vitamin C deficiency, lack of maturation of protocollagen, vitamin A deficiency, deficient epithelialization. Calcium, zinc, copper, and magnesium also affect wound healing. Debilitating diseases: uremia, jaundice, cirrhosis, diabetes, malignancy, delay wound healing. Drugs: steroids and cancer chemotherapy, immunosuppressive drugs impair wound healing. Local factors: vascularity, good blood supply in the face, scalp, nice healing, while poor blood supply, such as wounds below knee, delayed healing. Immobilization, movement, damages blood supply, delay healing. Irradiation and arthritis obliterans, leading to ischemia, decreasing wound contraction and granulation tissue formation. Tension increases tension such as sutures under tension, hematoma, infection leading to ischemia and impaired healing. Infection, fibroblasts compete with bacteria for oxygen and nutrition. Bacteria secrete collagenolithic enzymes to destroy collagen fibers. Foreign bodies and necrotic tissue impair wound healing. Complications of wound healing: wound failure, wound dehiscence. Due to general or local factors, failure of an abdominal wound is called burst abdomen. Stretching of the scar, hypertrophic scar in duration raised above the surface but limited to the scar. Course may regress within month. Site, common in shoulder and pre-sternal area. Keloid, overactivity of healing process, leading to excessive scar tissue in duration raised above the surface and extending beyond the scar. Course, progressive, even after 6 months. Sites, ear lobules, shoulder, pre-sternal area. Incidence, more in black persons and in familial predisposition. Contracture, if the scar overlies a joint, pathological shortening of the scar tissue leads to deformity. Avoidance, proper positioning of the joint. SSI, treatment of hypertrophic scars and keloids, continuous pressure by silicone gel sheets, intralesional corticosteroids, surgical excision, recurrence rate 80% after simple excision. To minimize recurrence, intramarginal excision of the scar plus intraoperative injection of steroids. Chronic wounds, definition, fail to undergo the usual sequence of healing within reasonable time due to factors affecting healing. Pathogenesis, arrested at inflammatory and proliferative phases of healing, with granulation tissue overgrowth, minimal contraction, and collagen formation. Management of general and local factors affecting healing process. Most share local hypoxia due to ischemia, trauma, and vasculitis. Examples: leg ulcers, venous, the commonest, ischemic, neuropathic, and neoplastic. Diabetic foot ulcers, pressure sores, bed sores, or decubitus ulcers. Type of the patient: bedridden due to high pressure applied on the skin. Risk factors: elderly, poor nutrition, anemia, ICU patients, paraplegia, denervation, immobilization, skin soiling by stools or urine. Common sites: heel, ischium, sacrum, malleoli, greater trochanter. Stages: erythema, partial thickness skin loss, full thickness skin loss, further tissue destruction, muscles, bone, and joints. Prevention and treatment: correction of general factors as malnutrition, skillful nursing care as turning in bed, assure dry skin, protect pressure areas by cushions or foam, air mattresses, regular surgical debridement and using vac, rotation flaps, myocutaneous or fasciocutaneous flaps. Surgical nutrition indications for the nutritional support: already malnourished patients, patients likely to become malnourished if not properly supported, hypercatabolic states as with major trauma, surgery, acute pancreatitis, burns, and sepsis, patients who are unable to eat for 10 days or more. Methods of nutritional support: enteral nutrition, parenteral nutrition. Enteral nutrition using GIT for nutritional support is generally better controlled and less expensive than parenteral nutrition. Indications: unconscious patients, burns, severe dysphagia, extensive head and neck surgery, low output anterior cutaneous fistulas, critically ill patients who have adequate intestinal function, and they are patients in whom oral intake is inadequate or impossible while having functional accessible GIT. Route of administration: tube inserted in the proximal part of the gut, nasogastric or nasojejunal tube, gastrostomy if nasogastric tube is not possible because of disease or obstruction in the upper alimentary tract, jejunostomy if stomach is diseased or with impaired gastric emptying with significant gastroesophageal reflux. Advantage of jejunostomy initiated within few hours of operation. Regimens and formulae for nasogastric tube or gastrostomy: liquid diet formed of soups, juice, milk, and blenderized food, well tolerated if given at reasonable rate. For jejunum, being highly sensitive, start with isotonic sterile formulae at slow rate, otherwise the patient develops distension, colic, and diarrhea. Tonicity and rate of gradually increased according to patient's tolerance. Commercially available formulae or elemental formulae require no digestion, ready to be absorbed. Daily requirements of an adult: 2 to 3 liters. Possible complications: mechanical complications, tube obstruction, pharyngeal and esophageal mucosal irritation and ulceration. Gastrointestinal complications: GERD, pulmonary aspiration, this is the most serious, nausea, vomiting, distension, colic, and diarrhea, usually due to rapid administration of the feeds. The natural route of nutrition by oral intake is the easiest and safest, should be attempted whenever possible. If this is not possible, nutrition is delivered by Enteral nutrition, tube inserted in the proximal GIT. Parenteral nutrition, caster in the venous system. Parenteral nutrition. In parenteral nutrition, nutrients are supplied intravenously. When used as a sole means of providing nutrition, it's called total parenteral nutrition, TPN. Indications: when the intestine is unable to absorb enough nutrients, as in massive small bowel resection, prolonged paralytic ileus, moderate to severe pancreatitis, high output intestinal fistula. Route of administration: as the nutritive solutions are hyperosmolar, thrombosis of veins occur. Rapid dilution of solutions with high blood flow reduces this effect. So we use a CVC inserted percutaneously through the subclavian or the internal jugular vein, and its tip will lie in the superior vena cava. Position of caster tip should be checked by chest X-ray. Exception is a lipid emulsion, which is isotonic. It can be safely administered through peripheral vein. Caster insertion should be under absolute sterile conditions. Regimens and formulae: daily requirements according to body weight plus the deficits. Daily readjustment depends upon monitoring of fluid, electrolyte, and nutritional status. Carbohydrates provided mainly by glucose. To avoid overloading the circulation, use high concentrations as 20, 25, or 5% of glucose. Proteins are commonly administered as L-amino acid solutions, which should contain the essential members. For the best use of amino acids to be incorporated into the cells, supply 100 to 250 calories for every gram of nitrogen. Fat emulsions available in 10 and 20% concentrations. Both are isotonic, can be given through a peripheral vein. Good source of energy because 1 liter of the 20% equals 2000 kilocalorie. Frequency: given twice weekly to provide essential fatty acids. They are not to be mixed with other preparations in the same bag. When using an amino acid per carbohydrate solution, gradually administered in increasing doses over 3 to 4 days to allow tolerance, particularly in regard to the increased output of insulin required to deal with the carbohydrate load. Amino acids and glucose are given spontaneously or better included in a 3 liters bag that is prepared under aseptic precautions in the hospital pharmacy. For optimal protein utilization, calories per nitrogen equals 10 to 250 kilocalorie per 1 gram. 6.25 gram proteins equals 19 nitrogen. Monitoring: aim to determine the efficiency of parenteral nutrition, detect its complications at an early stage. Methods: measuring body weight daily. Weight gain is more than 300 grams per day and is likely to be caused by water retention. Daily balance of fluid take and output: full blood count, blood urea, serum sodium, potassium and chloride, blood and urine sugar, and nitrogen balance. Thrice weekly estimation of plasma proteins, serum calcium, magnesium, and phosphate. Liver function test, blood coagulation. Manifestations of sepsis, fever, tachycardia, leukocytosis, and high CRP are always checked. Then we have possible complications. Nutritional and metabolic complications cause administration of improper amounts of nutrients, overfeeding, underfeeding, or specific nutrient imbalance, as hyponatremia, hypokalemia, hyperosmolar dehydration. Hyperglycemia is common and adjusted whether by reducing the rate of glucose infusion or spontaneous administration of insulin. Catheter complications, injuries during catheter introduction include subclavian artery, brachial plexus, and pleural. Pleural injury, hemothorax or pneumothorax, therefore chest X-ray should always be done after catheter insertion. If infusion set is accidentally detached from venous catheter, air can be sucked into the superior vena cava, which has negative pressure, leading to air embolism. Venous thrombosis, central venous catheter infection, and thrombophlebitis, serious septicemia if neglected and leads to death. Prevention: catheter should be introduced under aseptic techniques, and entry is inspected every other day, treated by antiseptic and covered by sterile impermeable dressing. The drip tubing should be changed daily. Never use a line for giving or withdrawing blood or giving the drug. Treatment: remove the venous catheter whenever the patient develops an unexplained fever which persists for more than 2 hours. Send it step for bacteriological and fungal cultures. Give broad-spectrum antibiotics, changed according to result of culture and sensitivity. A new central catheter is introduced at a fresh site. Failure of gut barrier, the absence of enteral feeding, atrophy of intestinal mucosa, leading to bacterial translocation from the human to the blood, leading to septicemia. Home parenteral nutrition indications: patients who had massive small intestinal resection, short bowel, A permanent celastic central venous caster, tunneled and cuffed, is placed for long-term use. Parenteral alimentation is usually given at night over 12 hours with the aid of a mechanical pump. And there are two notes. Malnutrition seriously affects the outcome of surgery. Whenever gut is functioning, it should be used for providing nutrition. Parenteral nutrition is not physiological. Frequency and seriousness of complications require close monitoring. Central venous line infection is very serious and can lead to sepsemia and even death. Whenever unexplained fever persists for 1 day, then the central venous line should be removed. And this concludes our part for today.